Welcome to Chapter 25, Birth-Related Stressors and Care of the High-Risk Newborn. Risk factors for NICU admission. Why do babies come to the NICU? Well, it's actually a variety of reasons. One of them is the maternal socioeconomic status. Mothers who have little or no prenatal care, that is a risk factor for NICU admission. Mothers who have poor nutrition, decreased maternal support, and a higher incidence of environmental hazards such as chemicals, illicit drugs, and abuse. If moms work in a plastics factory where they're exposed to, potentially toxic chemicals, well, that's going to be, has nothing really to do with low socioeconomic level, but that is more of like an environmental issue. It also comes from pre-existing conditions such as diabetes, maternal hypertension, or maternal infection. And you guys have already covered these in your high-risk OB section. Maternal age. Obviously, we used to say the older the mom, the greater the chance that your baby will go to NICU, but that's really not the case. There tends to be, in the NICU, we see a lot of young moms, and we see moms who are a little bit older. I'm going to jump back to maternal conditions here for a second because there's something that I forgot. Placenta previa, preeclampsia, which goes back to the maternal hypertension, premature rupture of membranes, prolonged premature rupture of membranes, and oligohydramnios, as well as preterm labor, are all pregnancy-related and medical complications. Placental abruptions, placenta accreta, cord injuries, uterine rupture, all these things are going to predispose a baby to come to the NICU. And then baby conditions such as prematurity, which leads to problems with the system immaturity. Basically, we're looking at the lungs, gut, and the brain, which leads to respiratory distress, hyperbilirubinemia, hypothermia, and then chemical disturbances such as hypoglycemia, hypocalcemia, and drug withdrawal. Classification of high-risk infants. There's a few different ways we can classify our high-risk infants. One is by size, and I introduced you guys to this terminology in a previous chapter. Low birth weight, VLBW stands for very low birth weight, and then ELBW stands for extremely low birth weight. Appropriate for gestational age, small for gestational age, IUGR, which stands for intrauterine growth restriction, and LGA, which is large for gestational age. SGA babies are common in moms who smoke or moms who have hypertension. These babies are also more likely to have polycythemia and hypoglycemia too. SGA and IUGR are often interrelated, but they can occur independently. In general, an SGA baby is just simply small, while a baby experiencing IUGR has suffered some sort of compromise, including maternal infection, cord issues, placental insufficiency, and other anomalies. IUGR can occur with preterm and term babies. We can also classify high-risk infants by their gestational age, and I've introduced you guys to this terminology as well, and then also by mortality. Live birth, fetal death, and so on and so forth. There's a great box in your textbook, and you should review that. So some of the factors contributing to IUGR. Remember, IUGR is the intrauterine growth restriction. As far as maternal factors, is the mom carrying twins or more? Is this her first pregnancy or her 19th? Is there a lack of prenatal care? Are there age extremities? Like, is she age 14 or is she age 44? Is there a low socioeconomic status due to poor living conditions and adequate health care? In the third trimester, maternal malnutrition and drug abuse really begin to limit fetal growth. Is there maternal disease? Maternal heart disease, maternal substance abuse, if the mother has sickle cell anemia, lupus, PKU, pyelonephritis, these are all things that can affect the growth of the baby. Complications from pregnancy include preeclampsia, hypertensive vascular disease, and diabetes because these conditions can decrease blood flow to the uterus, therefore decreasing fetal growth. It can also come from environmental factors such as high altitude, exposure to x-rays. So this is something that nurses really need to watch when they are pregnant and working in the hospital, just to make sure that they always step away from the area that's being x-rayed. Are the moms doing excessive exercise because they don't want to get fat? Is there exposure to work-related toxins, exposure to nicotine, alcohol, anti-metabolites, anticonvulsants? So you got to think about these poor moms who have a seizure disorder and they get pregnant. Moms who take narcotics, possibly for chronic back pain or some sort of chronic pain. Moms who take cocaine, or even moms who end up with a listeria infection from infected lunch meat. Placental factors include a small placenta, infarcted area, abnormal cord insertions, placenta previas. Fetal factors can be congenital infections such as torch, and we'll talk about that. Discordant twins, which means that the twins are not growing at an equal rate. That means that one twin could be 5 or 6 pounds, and the other twin may only be 2 or 3 pounds. Do the umbilical cords only have 2 vessels, or do they have all 3 present? Basically, fetal factors are anything that affects blood flow to the baby. As far as patterns of IUGR, it's important to determine if it's symmetric or asymmetric. And the differences are listed for you on your slide. But basically, if the insult occurs early in the pregnancy, then the number of cells is reduced and the total weight of the baby is reduced. Does that make sense? If the insult occurs late in pregnancy, the number of cells is there, but the cell size does not increase. Symmetric IUGR, again, the weight, length, and head circumference are all equally affected. This can be detected on fetal ultrasound during the first half of the second trimester, so that, 20-week ultrasound, we can detect this. Asymmetric IUGR is caused from an acute compromise of uteroplacental blood flow, such as preeclampsia. In asymmetric IUGR, the head circumference remains within normal parameters for gestational age, while the weight will rank in the less than 10th percentile. So due to the acute trauma, the baby may also experience electrolyte disturbances, including hypoglycemia and hypocalcemia. It's interesting, and I want you guys to think about this. A term small for gestational age baby will do better than a preterm appropriate for gestational age baby. Why is that? Why do you think that is? A term baby is always going to do generally better than a preterm baby, even if the term baby is small, due to organ maturity. A term baby's organs should be mature and able to function, and the fact is a preterm baby is just their organs, nothing is mature on them. Despite growth restrictions, physiologic maturity of the IUGR infant develops according to the gestational age. So that's at least a good thing. Despite the growth restrictions, so the baby won't grow very well, but the organs will continue to mature. So that's nice. So some of the complications of the SGA/IUGR baby would be, the first one would be hypoxia. Chronic hypoxia in utero. These babies have little reserve left to withstand the demands of normal labor and birth. Aspiration syndrome. This can also happen in utero. Hypoxia causes the fetus to gasp, even in utero, and that stimulates the release of meconium. Hypoxic conditions stress a baby. When you stress a baby, that makes them poop. It's not unlike grown-ups. When they poop, then they get poop in their lungs, and that is bad. Hypothermia. Remember that your SGA babies and your IUGR, they're growth restricted, or they're just small. So they're not going to be, these robust infants. They're not going to have a lot of fat. and they burn through their brown fat, their brown bat fat really fast. If they're preterm babies, you can add a lack of muscle tone to that mix because they don't even have muscle tone that they can try and use to conserve heat. Hypoglycemia. These babies have an increase in their metabolic rate due to the response of heat loss. They have poor hepatic glycogen stores, and they have inadequate supplies of the enzymes that are needed to start gluconeogenesis. These babies can have polycythemia due to the chronic hypoxia. If the baby makes excess red blood cells, which sets them up for hyperbilirubinemia after they're born. This also happens with moms who smoke. Congenital malformations, basically you should know that the more severe the IUGR is, the increased the chance, then there's an increased chance that it has resulted from impaired mitotic activity and cellular hypoplasia. Intrauterine infections, when babies are exposed to rubella or CMV, the virus invades the brain and other vital organs and causes IUGR. Growing difficulties. Small for gestational SGA kids, small for gestational age. These kids are usually going to be a little shorter. Asymmetric IUGR kids should catch up once they get adequate nutrition again. Symmetric SGA kids will usually always be small. They're always going to be petite, small people. Cognitive difficulties. A lot of these kids end up with learning disabilities. They may have short attention spans. They may have hyperactivity, poor fine motor coordination, speech deficits, and hearing loss. The treatment, it's important to, again, differentiate between SGA and IUGR. Diagnostic testing as indicated, which is pretty much going to be ultrasound. And then supportive management in terms of thermoregulation, glucose management, and overall growth. LGA babies. Babies at risk for an LGA diagnosis. Well, some babies just have a plain genetic predisposition. Large people tend to have large babies. Multiparous women, a multip, each kid tends to be a little bit bigger. If you ask moms who've had, 2 or 3 kids, they'll usually say their first baby was the smallest, the second baby was a little bigger, the next baby was a little bit bigger, and the babies just tend to kind of get a little bit bigger as you go along. It's interesting that boy babies are typically larger than girl babies. Conditions such as erythroblastosis fetalis, Beckwith-Wiedemann syndrome, and transposition of the great vessels can also cause babies to be LGA. The increase in size is usually proportional. The exception would be the infant of a diabetic mother, and we'll talk about that on another slide. Sometimes these LGA babies will act very sluggish, they're very listless, and they're lethargic. So you gotta have a little bit of sympathy for these LGA babies because they have grown a little too well inside mom. They're very large, and they gotta come through a pretty small, pretty narrow opening. And you gotta be able to fit just right in order to be born vaginally. So if they can't, or if they are too big, then these LGA kids, they are definitely subject to birth trauma from cephalopelvic disproportion, or CPD. Breech presentation, shoulder dystocia can often result in asphyxia for these babies. Flat asphyxia, that's a big thing to know. Fractured clavicles, brachial palsies, facial paralysis, phrenic nerve palsies. They can also have depressed skull fractures, cephalohematomas, and intracranial hemorrhages. Birth is not gentle, let's just say that. Moms who have a LGA baby are at increased risk for having a C-section. And then the babies themselves are going to be at risk for fluid and electrolyte imbalances such as hypoglycemia, polycythemia, or hyperviscosity. Simply put, Birth injuries are just the injuries that babies get from the process of labor and delivery. Sometimes they are completely unavoidable due to the way that babies present in the birth canal for delivery or because of prolonged labor. Sometimes elective C-sections are done to prevent an anticipated birth injury, especially if they know the baby is going to be big. Skeletal injuries, we've kind of touched on this on the last slide, but most skeletal fractures are going to be linear or depressed skull fractures. 70% of fractures are lineal and they heal without any treatment. If an artery is torn from the fracture, then the babies can get increased ICP and that will require treatment. Depressed skull fractures are called ping pong fractures. And I've seen babies with ping pong with a depressed skull fracture before. I have actually seen that in my career. Babies can also get fractures from forceps. Clavicles are the most fractured bone during birth. When babies fracture this, they often have limited arm motion. They usually have crepitus or the absence of the Moro reflex on that one side. Babies need very careful treatment of the injured area and they may need a little baby sling to immobilize their arm. The good news is that fractures in babies heal very quickly. Erb's palsy, it's also known as Erb-Duchene's paralysis, is caused by damage to the upper brachial nerve plexus, usually from shoulder dystocia. Signs of this are close to clavicle fracture. The arm is going to just hangs very limply at the baby's side. The less common is called Klumpke's palsy. Treatment is aimed at correcting the anatomical position of the arm. Most of these injuries heal by 3 to 6 months. If it doesn't heal, then babies may need surgery. Facial nerve paralysis can occur usually from forceps, and it can affect the baby's ability to eat. If the eyelid is paralyzed, then the baby may need eye drops administered round the clock to prevent an eye injury or have their eye just taped shut, which is really creepy. Neuro injuries can occur if the baby has been stressed in utero, usually from hypoxia. Babies can stroke in utero. I've seen it happen. I'm going to say that again. A baby can have a stroke in utero. One treatment is to do head cooling. They monitor the baby continuously and drop the core temperature down to minimize the damage from the hypoxic event. Then slowly the baby is rewarmed. Periventricular hemorrhage and intraventricular hemorrhage occur mostly in smaller premature babies because the vessels surrounding the brain are so fragile. The danger with neuro injuries is subsequent cerebral palsy, or CP, seizures, hydrocephalus, and later ADHD and developmental delays, including gross and fine motor skills. Some of these things are present until the child is much older. All right, so now let's shift gears a little bit and talk about sepsis. Sepsis is, as you guys remember, just the presence of microorganisms or their toxins in the blood or other tissues. In babies, it can be early onset or it can be congenital. Usually, it's going to manifest in 24 to 48 hours after birth. That's why it's nice if babies stay in the hospital for at least 48 hours after birth. There are 3 types of infections: bacterial, viral, and fungal. Late onset or nosocomial infections usually present between days 7 to 30 of life. Those can be related to invasive procedures. Also remember that babies in the NICU generally have decreased immunity, and just the fact that they are in the NICU sets them up for infection. Devices such as ET tubes, umbilical lines, PICC lines, ventilator equipment, all can contribute to infections in the high-risk neonate. Maternal conditions can also lead to infection. These include the presence of a UTI just before or at the time of delivery, or a prolonged rupture of membranes, certain STIs, and a positive group B strep status. See Table 25-3 on page 668 for more information. Signs of newborn sepsis. Babies do not present, when they are sick, they do not present the same way that other children, older babies, children and other adults are. Number one sign that a baby is getting sick is just that the baby has a change in their behavior. The baby just doesn't act right. They usually get very lethargic or they get very irritable. They start having color changes. They go from being a nice rosy pink to looking kind of pale. Sometimes they look dusky. Sometimes they even look kind of grayish and cyanotic. When babies start becoming a poor feeder, when they start sleeping through feeds, missing feeds, they don't eat as much as they normally do. They eat and then they throw up afterwards. They don't gain weight well. They're lethargic. They lay in their bed like a wet noodle. Those are all signs of sepsis in a baby. Sometimes babies can have a somewhat shocky appearance. They can appear they will feel cool to the touch, kind of clammy. They look very mottled and pale with poor peripheral vascular perfusion and or capillary refill. Temp instability is a huge one too. These babies get cold. They really only get a fever if it's a viral infection. But when babies have trouble maintaining their temperature, we always think hypoglycemia and we always think sepsis. One of the later signs of sepsis would be a change in baseline vital signs. Wow, that's shocking because that would be one of the first signs that you would think of sepsis in an adult. That's not the case in the neonate. It's one of the very last signs that they're going to give you. Depending on the source of infection, infants may display either tachycardia or profound bradycardic events. Septic neonates also display respiratory distress, usually in the form of apnea. So you're taking care of a baby and all of a sudden you notice that, gosh, this afternoon I've charted, 4, 8, that we call them A's and B's, apnea and bradycardic events. And you start scrolling through the flow sheet. Usually we have 1 a day. Now we've had 4 in one afternoon. And then you start looking at the temperature. Well, 4 hours ago our temperature was, 98.7, and now our temperature is down to 97.6. So we are not maintaining our temp, and then you start looking more closely at the baby and realize that they look kind of pale, and they didn't really wake up, this time for vitals and to eat. And come to think of it, they did have a little bit of a residual this time. These are all signs that a baby is sick. Do not ignore them. More signs of newborn sepsis. Hyperbilirubinemia. Why? Well, think about it. How is bili excreted? It's excreted through stool. If babies don't eat, then they don't poop. Therefore, the bili builds up and causes jaundice. Jaundice makes babies sleepy and lethargic. Feeding intolerance, and I just went over these on the last slide. Feeding intolerance and disinterest. Largely, this is related to the energy expenditure it takes for babies to feed. See Table 25-4. All right, so I love this slide because this tells you kind of pretty much what to expect. If you happen to be working in the NICU and you are taking care of a baby that you suspect may have sepsis, you're going to gather all your data and you're going to call the neonatologist and you're going to tell them what you have found and how the baby has changed since your last assessment or since the beginning of your shift. You should anticipate the neonatologist will order a CBC, a CRP, and a blood culture. Now the blood culture, you're going to have to do an arterial stick to get it because NICU babies generally have pretty crappy blood pressure and it's next to impossible to do a venous stick on a baby. So just plan on doing an arterial stick in their radial artery in their wrist. If they are intubated, the neonatologist will order a trach aspirate. If they are not intubated and it's RSV season, which is like October through April-ish, then they will probably have you swab their nose and nasopharyngeal passageways for an RSV panel. They may order HSV swabs, depending on mom's history. And sometimes even when moms have a completely negative history, because maybe mom's never had an outbreak and didn't know she had it, then they will go ahead and they will go ahead and swab the baby anyway. They will probably order a chest ab x-ray. If the baby is running a fever, the neonatologist or the NNP, the neonatal nurse practitioner, will come in and they will possibly order a lumbar puncture and perform that. And then they may order a torch panel. Sometimes they will order a torch panel and they will send it off on the baby's cord blood. But the T stands for toxoplasmosis, O stands for other, and they check for Hep B, parvovirus, HIV, West Nile, measles, mumps, varicella zoster, and syphilis. That's a lot of things. R stands for rubella, C stands for cytomegalovirus, and H stands for herpes. So one blood test and you can test for a whole heck of a lot in a baby. And usually they only send a torch panel like usually right after the baby is born if it's a preterm baby. After you've collected all your lab work, then you should anticipate starting antibiotics. So what antibiotics do you start? You could start a combination of ampicillin and gentamicin. You could start a combination of vancomycin and gentamicin. Or you may start clafrin, you may start cefepime, you may start diflucan if we think the baby could be septic with yeast, nystatin, amphotericin B if it's a fungal infection. They may start the baby on acyclovir if they think the baby might possibly have herpes, or Flagyl. Management of sepsis. What are you actually going to do as the RN? You are going to assess this baby frequently. You may be assessing this baby every hour. And I mean a full body head to toe, which, I mean, let's face it, they're only like, 18 to 20 inches long, so it's not like it's going to take you a whole long time. But you are going to assess this baby frequently. You're going to treat it early. Do we wait for the blood cultures to come back before we start treating the baby with antibiotics? No, we do not, because that would mean the infection would be too set in and we may not be able to save that baby. So we are going to go ahead, we are going to collect the cultures and start antibiotics, and the baby will stay on antibiotics until they prove to us via their blood cultures or urine cultures or trach aspirate cultures or whatever it is that we cultured, until those cultures prove that they do not have that, and then they may take them off either antibiotics or acyclovir or whatever it is they started them on. We will monitor them closely, very closely. That means you're going to be doing vitals every hour. We will also reduce environmental exposures. This includes screening your visitors, especially during heightened cold and flu seasons. So right around that January to April mark when influenza tends to hit this area pretty hard. If anybody shows any signs and symptoms of being sick, you're out of here. You need to come and visit later. If you absolutely can't, you need to wash your hands, don't touch anything, put on a mask, try not to breathe on the baby, try not to kill the baby with your gross germs. Hand washing, though, is the single most effective measure to reduce hospital-acquired infections. So wash your filthy little paws. And this concludes part 1 of the high-risk newborn.